The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Hello.
Yep. Good afternoon, everybody. You're listening to Cancer Update, a short walk through a long journey. You are here on this wonderful Friday afternoon with Dr. Dennis Birnbaum and Tina Withrow, patient navigator. I hope everybody's doing well. And Dr.
Hello?
B?
Can you hear me? Yes.
How
Hello.
you doing?
Let's give out the phone numbers to everybody. Locally, the number here at KAAM for Cancer Update, a short walk through a long journey, is 972-445-0770. And the toll-free number is 877-272-5226. How was your trip to Arkansas?
Oh, it was just delightful. I love hot springs.
Did you drive or fly?
We drove.
Did you have to go through customs to get through the border?
You're real funny. And our arms didn't hurt either. Oh, you're so cute. You know, I miss that sweet sense of humor that you have. I don't know how I did without that for 10 days. But it was great. That my husband is from Hot Springs. And we love Hot Springs, and we're very close with my husband's family. On a sad note, my husband's cousin, who is very close, we're very close with their family, was diagnosed on Monday of last week with a brain tumor, a very aggressive brain tumor. And on Wednesday, he had surgery and he remained in the ICU, and he was, you know, it's very shocking to have that kind of news. I have to tell you, though, dealing with the medical community here and dealing with the medical community there is a little bit different. I'm so used to things getting done so fast and being able to talk to the doctors and such. So we were glad. We were glad we got to be there.
Is this in Little Rock or Hot Springs?
Hot Springs.
Okay.
Mercy Hospital is where he was, and he got good care. We were glad we were there to be able to sit in the ICU like everybody else does and do all those things with family. But I do have some questions for you regarding a glioblastoma. Glioblastoma is one of the more aggressive brain tumors, correct?
Probably the most aggressive primary brain tumors. It's not metastatic, so people have to understand, just like in if you have breast cancer and spreads to the lung is a metastatic lesion. It's not a primary lung tumor, so you treat it as a breast cancer spread to the lung. A glioblastoma is a primary brain tumor. It has not come from point A to point B, the brain, so it's treated dramatically different.
Do you have to worry, will a glioblastoma spread anywhere else?
It can, but rarely.
It rarely does.
The biggest problem you have with a glio is that it will continue to grow in the head, and then it becomes what is called a space-occupying lesion. Because it grows, it pushes things around in the brain, and there's only because it's a confined cavity with a skull keeping everything confined, unlike the abdominal cavity. If you have something in the abdomen and it pushes things, the colon aside, then you've got room to move. The brain is a concealed self-encased cavity, and you don't have much room to move. So when it starts expanding, it is a space-occupying lesion and presses on things. And when you start pressing on things in the brain, it's not good.
How he came to be diagnosed with this, I thought this was very interesting. His family had noticed that he was just not as engaging as he once was. But his employer had noticed that his appearance was dramatically different. He seemed more unkempt. couldn't seem to hold a thought process, and he was doing something very high up, and his boss looked up at him on this scaffold and noticed that he was staring into space, thought he was going to step off the scaffold to imminent harm or death. And when he got down off of the scaffold, his boss went to him and said, "You are relieved from duty. You have to go get a medical release right now." And he went to the doctor that afternoon, and they did the MRI on Monday.
Like anything else, in brain tumors, it depends on where it's located. If it is located in certain areas of the brain, then it will affect your motor function. If it's located in other areas of the brain, it will affect your sensory functions and your cognitive functions. So obviously this was located in an area that was affecting his cognitive and sensory functions. The treatment of choice of primary brain tumors, which can be a glioblastoma multiforme, an astrocytoma, an oligodendroma, it goes on, is surgery. Surgery is the treatment of choice. Because it's in a very confined area and it becomes a space-occupying lesion causing problems because of size engorgement, you want to take it out surgery. I hate to say this, and I don't mean to sound gross, it's really not surgically removed. It's sucked out. Okay, it is a probe that goes in there by the neurosurgeon, and they the lesion is sucked out of there. It's not exactly cut out.
Oh, because I thought they said it was a softball.
2 years ago until it was explained to me. Now, there are different approaches. If you all remember, the late Ted Kennedy had a glio.
Oh, that's right.
And what they did with him, and I don't know if they did this with Jim's cousin, after removing the tumor, they put a Gliadel, Gliadel wafer, which is a radioactive wafer. You can put it into the brain, and it gives a permanent emission of radiation therapy while in the brain. And then you can also have different type of wafers that have some forms of chemotherapy. Remember, there are only certain drugs that will go across the blood-brain barrier. Most chemotherapeutic agents are very restricted in how many get across the blood-brain barrier. That's why it's very hard to treat not only metastatic cancer, let's say from the lung to the brain, but primary brain tumors.
What do you mean when you say blood-brain barrier?
There is a imaginary barrier. Rather than go into the anatomical, physiological description, let's just say there's a sheath that protects the brain, and only certain things are absorbed into the brain. Glucocol, sorbitol, that's why dextrose or Decadron is absorbed into the brain and cuts down swelling. It's one of those agents that will go across that barrier. Most drugs will not go across the blood-brain barrier.
Is that because the brain is so magnificently protective?
Extremely protective. So, having said that, one of the reasons why the drug Avastin was approved for primary brain tumors was because of Ted Kennedy. The work done at Dana-Farber Institute in Boston did some of the original work in the drug Avastin, which had been shown to be very effective in colorectal, metastatic, shown to be effective in non-small cell lung, shown to be effective in metastatic renal cell. They tried it in breast cancer for about 18 months, 24 months, and they said the studies did not say it was effective in that. It's now effective and used in metastatic melanomas. It really was not approved for primary brain tumors until Ted Kennedy came into the picture, and he agreed to be a guinea pig for it, and they tried it on him. And even though it did not improve his survival dramatically, it did improve it by about 90 to 120 days. You say, well, that's not very much. Well, it was long enough that gave him an extra 120 days in a very rapid onset clinical trial. Now it is shown to be effective in an even longer period of time, 6 to 9 months, with the use in combination therapy. So he was one of the pioneers in opening the door in the use of Avastin for the treatment of primary brain tumors. So it just depends on what approach they used on your cousin.
Is it always fatal, Dr. B?
Always is a very difficult word. I know some patients that have had both glioblastomas and astrocytomas and oligodendromas that are still alive.
Okay.
I think a lot of it depends on whose hands is handling it, what neurosurgeon and what medical oncologist are working together as a team, and how aggressive they are.
I've heard also, you've treated glioblastomas, and I have to be real careful because my first inclination is I want to get people on the plane and ship them here, and that isn't always.
It's hard for them to get on a plane. They can't get on a plane because of the cabin pressure will affect their brain tumors.
So,
this is true. We had, it wasn't my patient, but there were studies out there that showed patients wanted to go down to MD Anderson. They wanted to go to a major cancer institute. They had a brain tumor, got on the plane, and they coned down their brain tumor, and they died. And they found out it was the change in the cabin pressure that affected the brain. So then they found out they were going to have to drive. Things like that have changed. You have to put them on high-dose Decadron to cut down the intracerebral edema, which was causing the problem in the cabin pressure. So now they're able to go there. But fortunately, a lot of institutions around the world, around the United States, are more aggressive in their approach to brain tumors, because if taken aggressively, and you do not have a cross in the midline of the brain.
That was going to be my next question.
Okay. If you don't have a cross in the midline, and it has not gotten into the deep thalamus and hypothalamus area, then there is a much greater chance of responding from surgery, intracerebral glial radiation wafer, and the use of various treatments. It used to be, and one of my colleagues from MD Anderson and I, back in 79 and 80, when we came here.
I was still a baby then.
Yeah, right. Big baby. We tried intracarotid artery perfusion of chemotherapy using a nitrosourea BCNU. Now, that was in experimental days, and when we gave it, every patient on the table had a seizure. And a couple of the hospitals we did it at just went crazy. You're sitting there giving this drug, and everybody's having seizures. Then we found out you really needed to intubate the patient, put them asleep, and then do it. And we were getting some fairly good results in giving a nitrosourea because it crossed the blood-brain barrier and was very effective. Then we tried the oral nitrosourea, CCNU. So there are drugs that will work. And it just, again, goes back to the point, you've got to talk to the patient. You got to figure out how aggressive do you want to be, because I firmly believe that there are treatments that will work in the primary brain tumors.
The brain is such a complex thing. I was amazed when he came out of surgery. He did have some paralysis on the right side, but they were working with him, and it seemed to come back pretty quickly.
Yeah, it will resolve itself. The problem you got with the brain is the same problem we talked about before. You got the big skull. It is a self-encased system. It has no room to expand. No different when you have a metastatic tumor. What's the first thing you got to put them on is steroids to cut down the swelling. It's like if you get a splinter in your hand. Just think about this. I'm talking to the audience. You get a splinter in your hand and you get a red eschar or a red swelling. Same thing in the brain when you get a foreign body, i.e. a metastatic brain tumor or a primary brain tumor. You get an eschar, a swelling, an inflammation. So the first thing you got to do is reduce that swelling, not the tumor itself. The tumor itself is infinitesimal, it's very small, but it's the swelling that really causes the initial problem. So you want to stop the swelling, so you give them steroids, Decadron. Now, steroids are fraught with side effects. You get cushingoid, you get swelling in the face, you gain weight, you become a drug-induced diabetic. You could develop steroid psychosis, muscle atrophy, ulcers. So there's some side effects you got to worry about.
For long-term use?
Well, even short-term use because you're using a high dose. But at the same time...
What's considered a high dose?
Well, you're giving anywhere from 8 to 12 to 20 milligrams of Decadron, which is a long-acting steroid. It has a really, it's like 20 times that dose of prednisone. So using the drug, you will see a dramatic improvement in their neurological symptoms where they're having headaches or dizzy spells or forgetfulness, recent or long-term memory changes. Within 24 hours after being on the Decadron, a lot of these symptoms all disappear, and they feel a lot better. And then you gradually, for example, we recently had a patient that had whole brain radiation. You have to give it while they're on the radiation because not only will the tumor, the metastatic tumors themselves cause the swelling, the brain radiation is like getting a big sunburn, and it's going to cause some swelling. So you got to leave them on the Decadron for even when they finish the radiation. You talk to most radiation oncologists, they want to keep them on the Decadron, and then you gradually wean them off the Decadron from 4 milligrams 3 times a day to 4 milligrams twice a day to 4 milligrams once a day to 4 milligrams every other day, and then you stop it. And that's over a 6 to 8 week period of time. When you have a primary brain tumor, you've got that skull, again, we go back to this discussion, it's self-encased. The skull can't expand. The tumor can't expand. There's no place to go, so it's putting enormous internal pressure on the brain. And again, it depends on location. If it's in an area of cognitive function or sensory function, then you're going to have problems with paresthesia, numbness, tingling in the hands. You can't pick up a cup of coffee because you don't realize hot from cold. So you've got to be real careful. Or it could be motor function. You can't pick up a pen and write. You can't open the door. So again, it depends on where it's located. But in general, and a lot of that is due secondary to the swelling that has occurred in your brain. So by you giving the Decadron, the steroid, you cut down on the swelling. And then their symptoms and their signs and their ability to function improves dramatically. So it depends on what they did for Jim's cousin, whether or not they did surgery, whether or not they put a Gliadel wafer in, whether or not they're going to put him on Timidor, which is an oral dicarbazine, DTIC, which is very effective in metastatic tumors and primary tumors of the brain, and what protocol they're going to put him on. You know, I don't know the program up there, whether he's going to the university in Little Rock to get his evaluation. But there are a lot of protocols out there, and depends, again, on the location. Mm-hmm. Is he getting a gamma knife radiation or postoperative radiation?
Yeah, I don't think they've made that determination yet. He's going to go see the doctor this next week. Along those same lines, another question that I had is my mother-in-law passed from a glioblastoma. So this would be his aunt. And then
Are they on the same side of the family?
Same side of the family.
Okay.
And then his mother, Henry's mother, had I think colon cancer with mets to the brain.
Definitely falling into the cancer family syndrome.
But is there any genetic connection?
I don't know if there's a genetic connection in primary brain tumors. I'd have to go back and search the literature. But he definitely, Jim, your husband, ought to fill in our graphic on cancer family syndrome, because now he's got relatives, cousins and all, who have all had cancer. He needs to fall into the calculation and see if he's at risk.
I was talking to everybody about that. Thank you so much for bringing us up to date.
All I got to say is, You and your husband have lousy gene lines.
Gosh, don't we?
You've got 5 members of your family, your immediate family, who've had cancer. Jim's
Mother,
got all
father, 5 siblings.
Look, are you all drinking certain kinds of water or
something? There is something out there. I have to tell you, it's amazing.
Don't take this personally, but why don't y'all stay away from my house?
That's exactly right. And just to follow up to end off on brain tumors, that is very different. Glioblastoma of the brain is very different from somebody who has lung cancer with mets to the brain. Correct?
Totally different.
And
real simple. If you've got X cancer, colon, breast, ovarian, stomach, lung, and it's spread to the brain, you treat it as the primary. If it's lung to the brain, you treat the lung cancer, which will then treat the metastatic lesion. However, in a primary brain tumor, the treatment is totally different. The drugs are different. The approach is different.
I didn't want
the primary treatment, and don't misunderstand what I'm saying, i.e. the great Lance Armstrong. He had metastatic tumors to the lung and brain from his testicular cancer, and they did surgery on it plus chemo and radiation. A lot of times you will do surgery on metastatic cancer from another primary to the brain. And a lot of times you don't. You'll just give them chemotherapy. However, in primary brain cancer, the treatment of choice is surgery. I
thought it was very interesting. I sat there not wanting to be the pushy broad when the doctor was talking to him. They didn't have a navigator, and their doctor seemed like a nice guy, but he wasn't real aggressive. But he did let them know that if he chose to put them on Timidar and they could not pay their 20%, that he definitely was going to die from not taking the drug, versus saying, well, we have ways to help you pay for the 20% that your insurance doesn't pay for. There are programs out there, and let somebody, a social worker or a navigator or whatever, help you.
I will tell you this, in the past 2 weeks, I have had some very interesting encounters with various hospitals and various patients who came to us from other oncology groups for second or third opinion, and how big a difference it is when they know that there are grants out there, or somebody like you as a patient navigator, that none of these facilities, none of their previous oncology groups had navigators, and how much different it makes in having a navigator work with the patient, work with their insurance company, i.e. our gentleman the past couple of days, I'll just mention his first name, Jose, who was in the process of losing his insurance, and he was oblivious.
He really was.
I mean, oblivious to the reality that, hey, you got to pay somewhere between $350, $400 premium, or we can't see you, nor can we treat you anymore.
Or nor will anybody else.
And I don't think he understood the severity of his situation, being in the middle of his treatment in complete remission, and he didn't realize that his premium had not been paid. So having a patient navigator and having a team that makes the patient aware of things that are out there to help them, as opposed to patients who don't have that, it is a dramatic difference, not only in treatment, but in quality of life and in sanity of their brain in dealing with what they're going through. It just eliminates the anxieties that they're going through.
Well, you mentioned insanity. Last week and this week, that was kind of the thing that would go around in my head, the insanity of cancer. Just, it's very rewarding for me to take somebody who is just so beside themselves, almost an out-of-body experience, and they're anxious, their eyes are darting around, they're not real sure, they're trying to do 50 things at once. Do I need to apply for disability? How am I going to pay for this? If I don't work, I don't get paid, and all of that. And it's very rewarding to just take some of that burden off of them, and to be able to show them the ropes of it in light of this terrible, horrible disease. This week, coming back by the end of last week, I was kind of chomping at the bit to get back. My husband calls my cancer survivors my peeps. He said, "You're anxious to get back to your peeps." I said, "Yes, I need to kind of make sure that they're doing okay and that everybody's been taken care of." Question for you, Dr. B, as we move on, screening. I want to know, again, just to reinforce screening. Different things are coming about with screening. We had a woman who called and left me a message this week, and I've been talking to her once or twice, and she is a never smoker who had stage 4 lung cancer. And I was talking with her about, hydration, and we kind of got off track. And I said, we in this country, we do a lot for research. There's billions of dollars for research. But wouldn't it be novel? I just want to throw this out to you. Wouldn't it be great if there was this van or this big motorhome? I just want to say this in case you win the lottery and we can do this. That went around to do free screenings to catch these people. I mean, here was a woman living her life, doing what she needed to do, and she had stage 4 lung cancer, and she was a never smoker. So I just want to know that if there weren't socioeconomic barriers, if there weren't, who's going to pay for it, who's going to pay the radiologist, whatever, what would you like to see people do? Not insurance, I'm not talking about any of that. People do in the way of screening, and what we could provide in this country in the way of screening. I personally would love a van that did nothing but vaginal ultrasounds. I know that sounds crazy, but that's the one way where you find ovarian cancer. So just tell me what you would do. Pie in the sky. He's thinking.
Well, we've done it. I mean, when we opened up the cancer center in McKinney, we did 1 full month of cancer screening for free. Total body scans, free PSAs. We arranged with another imaging center because we had every x-ray imaginable in our cancer center, from PET, CT, MRI, etc., bone densitometry, but we did not have mammography. And the reason is, to be quite honest, the radiologists did not want the liability. They have to take out extra malpractice insurance, the radiologist does, if you're going to have digital mammography. So, I'll be quite honest, that's the reason why we didn't put it, only because of the increased liability. When we reopen the cancer center very soon, we're going to have digital mammography there. We already have breast ultrasound. But when we did that, when we opened, we did all the screening. I think there should be, at least every 6 months, a program of screening. Now, I will tell you that I ran into some, and it was very unusual, and I was surprised to see it. And at my age, I just don't give a damn anymore, to be quite honest with you, that a lot of doctors were against us doing this screening. They thought it was a gimmick. They thought it was something just to, bring business in. I thought it was good PR. I thought it was something good for the patients.
Served the community well.
Well, first of all, we picked up about 33 cancers that these people didn't even know they had.
Incidental findings.
And we had a bunch of aneurysms, abdominal and thoracic aneurysms, that were found that these people did not even know about. One of the neatest was the lady. She was at the time she was 68 years old. She's 74 now. We picked up a enormous renal mass, a renal cell carcinoma. I think if I had unlimited funds and a pie in the sky attitude, I think there should be cancer screening done on patients. I think I would like to further establish our foundation that we have now, that we use to help patients, not just indigent patients, but patients whose insurance is limited on their copay, and that there should be ways that drug companies participate more in the treatment of cancer patients and make drugs available. I'm not saying give free drugs, but allow patients who need it to be treated. A lot of times the only available place for patients to go, which is inconvenient, is to university settings. I'm a big supporter of like MD Anderson, some of the programs down at the medical school here. Dr. Collins' program in transplant is one of the best there is. So I wish that in a society like this to make things available and make it very transparent. I think that's one of the problems that I have with the Affordable Act, the Obamacare. I'm not saying everything in it is bad. There are some good elements in it, but to have a congressional leader say, "Well, we'll find out about it after you read it," 2,400 pages. But I think that whether it's a tax or whether it's what is in the affordable plan, overall, people need to really read it in its detail. Especially those people who go back and live with their parents who are on Medicare. It doesn't give them it. They have to go on COBRA. Unless their parents have private insurance, their parents or their grandparents they live with are on Medicare, doesn't apply to those people up to age 26. They have to be on COBRA. So you need to go read exactly what's in the Affordable Act.
Well, the other thing I have to tell you is, when the government gets involved, things get crazy. I've talked before on this show about the pre-existing insurance plan, and it's an Obama plan, and
You mean the PCIP?
The PCIP. It's really good.
It has some good
points in it. But gosh, leave it up to the government, because I've had 2 or 3 people and we currently have somebody who really needs it desperately. And we filled out all of our paperwork and we sent it in. And on the way here, we got on the phone and we were calling to make sure everything was in. And the woman said, well, you need to resend a piece of paper. And I said, what is that? I had the patient on the phone with me. And I said, what is that? And she said, well, you need to have, they need to be able to, a denial from what insurance company is going to deny them. You have to have a denial. You have to not be able to get insurance. And
so like they would have to have a denial, let's say, from Blue Cross United Healthcare because of pre-existing, and then once they have that denial, they send that into the PCIP.
Or you can have an agent just write a letter that says they don't qualify for insurance because they have colon cancer, which is what we did on this woman. An agent wrote a note that says she does not qualify for insurance because she has esophageal cancer. And that has always, in the 100 bazillion that I've done previous, that has been right. Well, on Monday we called and they said, yes, we have everything. Everything's set to go effective September 1st. And today when we called, they said, oh, well, we need that agent to go ahead and say which insurance companies they would be denied from, which is really, really stupid. But so I think we need to think closely, because if the government takes too much of it, it really could get messed up. We have a call. Nope, we don't have a call. Dr. B, talk to me about colon cancer treatment. Why does it seem like colon cancer treatment is a really long treatment? It just seems
most treatments, everybody's got to understand that everything was based on clinical trials, phase 1, phase 2 trials. And because of that, they have established to say that you need X amount of time to get the results that the trials indicate. So there may be one trial that is good for 4 months, another trial you have to take every other week for 12 treatments, which is the FOLFOX protocol, or the FOLFIRI protocol, which is 5-FU oxaliplatinum leucovorum for colon cancer that is non-metastatic. Some would try the FOLFIRI, which is 5-FU irinotecan leucovorum. Just depends on which one you want to use. Some would use simply 5-FU leucovorum. And each one of these, due to clinical trials done by various institutions, indicate how long the protocol should be, and those are the guidelines that you use. With those guidelines, they also have how often you should do certain tests, how often you should do certain blood tumor markers, or how often you should do certain x-rays. Now, that begins to change when the disease becomes metastatic, either at the onset when you first meet the patient and make the diagnosis, or if you treated them, they go into remission, then they come back and they've now got new metastatic disease. Those protocols are obviously a little bit longer. Once you develop metastatic disease, the treatment modalities are more complicated, they're more convoluted, and they need to be on therapy for a little bit longer. Now, I had a very unpleasant thing happen to a very dear friend of mine whose family member died recently. And I got involved at the last minute. They asked me to get involved. And I sent her slides off to another institution, down to Dr. Hamilton, head of pathology at MD Anderson, who I used to do a lot of my backup reading on slides. And
another pair of eyes looking.
Just another opinion. Like we've said many times, you may find your second or your third opinion should have been your first. And lo and behold, Dr. Hamilton called me and said, Dennis, what are they treating this patient for? And I told him, he says, well, they're treating him for the wrong thing because that's not what they have. And I said, you got to be kidding me.
So the patient, your friend, was treated like they had one type of cancer and they really had another type.
They were given the wrong medication,
the
wrong treatments. And I've always said, every patient that we see, every patient that I have, at no expense to the patient, I send their slides down to another institution just to get another set of eyes, another opinion.
It's got to be scary if you're out there listening, thinking that that could happen in these times, that really, really could happen. That's just, is that why sometimes when you have an unusual case, I've heard you say, if it looks like a duck and it walks like a duck, it's a duck, but if it isn't looking like a duck or walking like a duck, I mean, that's why you're sending that off, because probably your intuition, you rely on your intuition, I'm sure, these many years in practice.
And I'm not anybody magical. I've been doing this now 34 years plus 4 years at MD Anderson, and you see a lot over that period of time. And they tell me he's got colon cancer, but it just doesn't look like colon cancer, doesn't act like colon cancer.
That's what I'm talking about.
And it's such an early form of colon cancer, it should be responding, and yet it's not responding. So then, I said, well, let's send these slides off, and I send the slides off, and I'm told, it could be something else, Dennis. It could be another type of tumor that they're having. So what I'm saying out of this is I would recommend in today's society, in today's medicine, most of the time you're going to get accurate readings. Most of the time the pathologists are accurately approaching the disease correctly. But it does you no harm, and the cost is so negligible that I would have the slides taken off and looked at by somebody else. The other thing that really concerned me in dealing with this case was that they immediately jumped to a clinical trial. And that bothers me personally. When you have a lot of conventional protocols out there that are known to give you 60, 70, even as high as 80% response rate, but in order to pick up an extra $20,000, $25,000, $30,000 from a drug company, you immediately put them on a clinical trial without using conventional therapy. And the clinical trial may have some good results, but it's truly not proven yet. But in order to pick up that extra $20,000 to $30,000 from the drug company, you're going to put them on a clinical trial rather than using conventional therapy that works.
Yes.
That personally bothers me more than anything else.
We'll be back. I've got some more questions for you, Dr. B. Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
You've been listening to Ask the Pros, heard every
Good afternoon, everybody. This is Dr. Dennis Birnbaum with Cancer Update, a short walk through a long journey. The phone number here is 972-445-0770, and the toll-free number is 877-272-5226. I was just notified by Tina through her husband that y'all weren't listening to us for the first 30 minutes. There was no transmission. I'm sorry. I don't know what happened, but we'll continue on where we are. Tina, you wanted to talk about fanny packs and little balls that people carry around with them.
Well, let's kind of regroup what we were talking about originally. I was just talking about different types of treatment, and Dr. Birnbaum was kindly explaining how some of that works more in a layman's terms. So I'm just going to back up just a little bit. For Dr. B, for the treatment of colon cancer, one of the questions I had asked and you'd already answered is, why does it seem that colon cancer is so long? Sometimes I notice that patients take their chemotherapy home. Can you just explain the why? Is that because their treatment wants them to have it over much time? But I notice I'll see people either carry something or have something over their shoulder. If you could just explain what that's about.
Well, it depends on the protocol. For example, one of the protocols for colorectal cancer is the use of 5-FU. In Edward Kim's book, if you look at it, it talks about 5-FU, 400 milligrams per meter squared as a bolus injection, which could be...
Means nothing to me.
Okay, well, 5-FU, 400 milligrams of the drug per meter squared. Your meter squared is your height and weight. You and I would be 2.2 meters squared.
He always wants to put me in that little bucket.
Well, you got 400 times 2, that's 800 milligrams. And you give it as a bolus over 2 to 3 hours. Then the next phase of it right below it says 600 milligrams per meter squared. So let's just say your meter squared is 2 times 600 is 1,200 milligrams over CI, continuous infusion, over 22 to 24 hours. Well, the office doesn't stay open 22 to 24 hours.
Right.
So we set them up with it can either be a little ball. All the drug is put into this little ball, 100 cc little ball, and it's calibrated by a pole, a calculating, and that's dripped into you over a 24-hour period of time.
I see.
So you take it home with you. It's attached to your side. When I had MRSA infection, they put a vancomycin antibiotic ball attached to me, and I would have it changed every 24 hours because they wanted to have a continuous infusion. A lot of reasons. For example, it used to be an anthracycline, adriamycin. We would give that in the hospital over 24 hours. Why? One, you get better cell kill effect. If you look at a graph, you get a sudden increase in the drug concentration. It stays at an elevated level at a peak and stays concentrated in the blood, so you get a better cell kill effect in a 24-hour infusion. And there's less toxicity when you're giving certain drugs over 24 hours. In 5-FU for colorectal cancer, the studies show that there's less neutropenia, meaning a drop in the white count. There's less nausea and vomiting. There's less stomatitis and mucositis of the mouth, inflammation of the mouth, when it's given over 24 hours. So you have less toxicity, better quality of life, and better cell kill effect. Now, there are drugs that they've shown, doesn't matter if you give a continuous drip over 1 hour, 24 hours, or 48 hours, it's all the same. It has no change in the dynamic and the effects of the drug. There are certain drugs that work better over 24 hours. Either they get better cell kill effect or the toxicities are much less, therefore the quality of life while they're on chemotherapy is better. 5-FU with FOLFOX and colorectal cancer is better. Anthracycline, adriamycin, or epirubicin has shown to be better when given over a 24-hour infusion. Has less toxicity to the heart, the anthracycline does, when given over 24 hours. Now, certain recent drugs they have found, like cisplatin, some of the platinators have been shown to have less toxic effect on the kidneys when given over 24 hours rather than when given over 2 to 3 hours. And there's less pressure or strain on the kidneys, and there's less changes in the kidney function when it's given over 24 as opposed to when it's given bolus over 2 to 3 hours.
Do you have to worry about something happening to the chemotherapy if somebody takes it home, or you don't ever have those kind of problems, correct? As far as, it's in that little thing, but does it stay protected? You've never had trouble with somebody spilling it or...
Oh, you always worry about that. The ball is self-contained, and it's an IV hooks into the ball, and an IV hooks into you or your Mediport. Now, you always have the risk that, it gets hold of a wheelchair, gets a hold of a doorknob, and it pulls loose. That you always have to worry about it. But in general, no. You really don't worry about something like that. They're pretty secure. A lot of them, you get a little fanny pack that the patient will carry either strapped around their waist or over their shoulder. I've even seen people with the pack along their back, like a knapsack they put on their back, and it's hooked up to their Mediport, which is in their chest, and they go on and do their normal daily activities. Women go do grocery shopping, take care of the kids. It's hooked up as a fanny pack around their waist, and they do their normal daily activities. One
thing I want to speak to this afternoon is I had a caller call me this week whose father is a listener on this show, and she was talking about hydration, and I told her that we would talk about that. We really think that we can take in enough liquids to keep ourselves from getting dehydrated, and that is not true, correct? We really fall short, most of us, as far as being properly hydrated. Would you agree?
In generality, I agree with you most of the time. And the problem you run into is the drug that you're taking. Most chemotherapeutic agents will dehydrate you. Most chemotherapeutic agents will give you some diarrhea or change in your bowel function. And remember, every loose bowel that you have, and I don't mean to be gross here, you're losing about 500 cc's to a liter of fluid with every loose diarrheal stool. And if you have just a really heavy blasting diarrhea, you could be losing, and you don't realize it. You come back from Mexico, you get Montezuma's Revenge, you have a loose bowel, and you're on the toilet, 4 to 5 minutes. You don't realize you could be losing 2 liters of fluid, and you feel weak afterwards. And then you're stupid, and you go back out in the sun on the beach, and you really get lightheaded and dehydrated even further, and you're behind by about 2 to 3 liters. It takes a while to replenish that. Chemotherapy is almost the same way, and God forbid you've got to get concomitant radiation with it. Then you're really wasted. Not only are you dehydrated from simple free water, but you're losing a lot of electrolytes, magnesium, calcium, phosphorus, sodium, plus nutritional elements. So
have you
gotta
ever been
replenish it?
Have you ever been dehydrated yourself?
From a sunburn out in the ocean, out on a boat? Yeah.
I've only ever had that happen once, but I did not feel good at all.
Oh, you get very lightheaded and dizzy and just lousy feeling. And you want to go back and lay down in a hotel, but what you really need to do is hydrate. Either get under a shower and hydrate yourself that way for the body to absorb liquids, the skin to absorb, but also get yourself a pitcher of water and start drinking. Because it takes a while, but it's necessary. You see it every week during football season. These athletes get dehydrated. They're hooked up to IVs. I mean, they're taking liters or 2 liters, and these are prime, well-conditioned athletes who are like little kids when they get dehydrated, because it can really deplete the body. It makes your muscles very tender. It's one of the easiest ways they pull muscles, pull tendons, and get hamstrings in Charlie horses, because you're depleting the body of electrolytes, of sodium, of potassium. So you need to replenish that. And it's amazing to watch these very high, fine-tuned athletes. You give them a bottle of fluids with potassium or sodium in it, and all their discomfort and pain and stress goes away.
I've heard that quinine works for Charlie horses. Is that true?
I've heard the same thing. It's probably because of what you're replacing.
Oh, really?
Yeah. But the thing is with chemotherapy, because it is, if you're able to hydrate yourself, I cannot explain to you how important it is. You hear me talk to patients. If you're on a platinator, because it can affect the kidneys, you've got to hydrate yourself. And 5-FU affects the bowel. And one of the reasons why you get such profound diarrhea with 5-FU is because it depletes the bowel of electrolytes, of magnesium. And magnesium is part of the treatment for constipation. So when you're losing magnesium in your bowel, it just opens it up, and it's a floodgate for just massive watery diarrhea. So you've got to replace it.
Okay. Tell me, if someone wants to get in touch with you, what is the best way that they should get in touch with you, as far as email, phone? What do you prefer, Dr. B?
Either way, at my age, I don't care anymore. I'm used to it. The office is 469-453-5500. The office can always reach me. If you really absolutely need to get me, you can call me on my cell phone at 214-543-4040. I'm available all the time, whether it's morning, afternoon, or evening. We've always made it a part of our practice that the doctors are available. You're available as the patient navigator 24/7. I think in order to maintain an oncology practice and to be efficient at what you do, you got to be available to the patient. I've always thought that if, God forbid, I had cancer, I'd want to be able to talk to my doctor. I don't want to talk to a PA. I don't want to talk to an MA, and nor do I want to talk to a doctor on call. And you say, well, you can't be on call all the time. I don't know. Most patients are pretty respectful, and they're not going to call you at all ridiculous hours of the day. They're pretty courteous. And I think eliminating questions, I have an old saying in our practice, I don't want to know on a Monday if you had a problem on a Friday. Because by the time they get to me Monday, that problem is really serious. And it's more difficult to take care of. And it'd be a lot easier to take care of it on Friday.
You were talking earlier in the show about, this friend who was treated somewhere else for personal reasons. She started out somewhere, and sometimes you start out one place and you just don't want to make the change, and you're sick and tired of being sick and tired, so you stay where you're at. And unfortunately for her, it didn't work out. And then when they finally did get you involved, you found out that she was really being treated with the wrong treatment. That brings me to my next question. I had someone call me this week and ask me this question. She has breast cancer, and she was triple negative. Seems like there's been a run on triple negative
That
women.
means she's ER, estrogen receptor, PR, progesterone receptor, and HER2, Herceptin, HER2 new negative. All three are negative.
Correct. So that was, terrible. And
Was she premenopausal or postmenopausal? How old was she?
She's 47, 48.
So she's right at the perimenopausal period of time. It's even worse if you're triple negative and you're premenopausal. It's negative. It's a bad prognosis if you're triple negative in general. Their latest study came out back in December, I believe it was, that showed that triple negative women have a higher incidence of recurrent disease and have a higher incidence of brain metastases.
Well,
So they got to be watched closer.
yes, I agree 100% with you. So she did chemo and she did radiation. She started with chemo, then she went to surgery. She had a mastectomy, and they sent the tissue off. And she had the biopsy was sent off, and that's how they came up that she was triple negative.
Right.
But then they sent the tissue off of her breasts
To Caris.
to
Or
Caris.
some company like Caris.
Yes. And then she was found to be 45% positive. So that doesn't make her a triple negative anymore, correct?
Well, if I get back something like that, then I immediately get the original tissue and send it down to MD Anderson or send it down to some cancer institution to have it reevaluated.
Oh, okay. Because, I just thought that the first diagnosis would be it. So thank you. Thank you for answering that. We want to thank everybody. This is Cancer Update, a short walk through a long journey. We're going to have a guest next week. We hope you will listen in. We do apologize that you were not able to hear us the first half of the segment. It was profound. It was wonderful. It was featuring me and my return back to the radio waves, but that's okay. You missed it. I'm sorry. I hope
The largest source of untapped natural gas.
Thank you so much, everybody.
If you need anything, please call our office at 469-453-5500. Have a nice and safe weekend. It's Labor Day weekend, everybody, so be safe.
Bye now.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.